Ladies and gentlemen, I'm pleased to invite Dr. Visakha Ratnamalala to deliver her lecture.
Thank you very much. Good afternoon, everybody. First of all, I must thank for Sri Lanka Obstetricians and Gynecologists Association for inviting me for this evening to talk about anemia in pregnancy, which is a very, very common problem in Sri Lanka as well as the world. So, definitions of anemia. According to the WHO 2011 definitions, the normal male person should have more than 13 grams of deciliter hemoglobin. And for a normal female, adult female, more than 12 grams per deciliter. But in pregnancy, less than 11 gram per deciliter is considered as anemia. So, I have shown here the classification given by the World Federation, WHO 2011, according to the moderate, mild and severe anemia. So, if we this is given in grams per liter, therefore those are mentioned in 110 that way, but usually we use 11.0, 11.9 in that indices. That those are our units. So, non-pregnant female, mild anemia we consider when it's less than 12, that is 11.9 grams per deciliter. And for moderate anemia, 8 to 10.9. Severe anemia less than 8. For a pregnant female, this is little lower. Mild anemia we consider when it's 10 to 10.9, that is 11, right, grams per deciliter. And the moderate anemia is 7 to 9.9, 7 to 10 grams per deciliter. So, less than 7 is considered as severe anemia. So, I'll go to the causes of anemia. There are large number of causes, of course, but basically we can divide into several groups. So, nutrient deficiencies are the commonest. The iron is the commonest, of course. Inadequate diet, inadequate absorption of nutrients, and the infections when there's malaria, parasitic infestation, and TB, HIV, inflammation. All these things can cause anemia. So, the chronic diseases also there are, that is rheumatoid arthritis, SLE, any form of chronic diseases, the diabetes, endocrine causes. Then acute or chronic blood losses are common. Gastrointestinal bleeding or heavy periods. It is the most common, the heavy periods in obstetrics. So, inherited red blood cell disorders we have to consider. In addition, hemolytic anemias. Out of that, the hemoglobinopathies are the commonest problem. And hematological malignancies, pre-malignant conditions, we have to think of when the patient comes with anemia. Dilutional anemia is common in pregnancy. So, I think all of you know about that. The dilutional anemia is the we have to always think of dilution of red cells by increased body fluids during pregnancy due to water retention. And the bone marrow failure, aplastic anemia, myelodysplastic syndrome are other causes. So, as the iron deficiency anemia is the commonest, WHO also gives the prominent place for that. I will talk about it initially. If we think about prevalence, WHO estimates 40% of children 6 to 5 years, that is 6 to 59 months of age, are iron deficient, and 37% of pregnant women are iron deficient. 30% of women in childbearing age, that's 15 to 50 years of age, worldwide are anemic. Affects more than 56 million women globally, and 2/3 of them being in Asia. So, iron deficiency anemia definitions for the pregnant females in the first trimester, you can think it's given the cutoff level as less than 11. And for the second and third trimester, 10.5, and postpartum period less than 10. So, the effects of anemia, there are a lot of effects. As you know, maternal fatigue, they have hair loss, they're getting angry, sleepiness, all these symptoms are there. In addition, poor quality of life because of this anemia. So, if we consider the other consequences, the postpartum depression also common when the patient is anemic, and altered thyroid metabolism also researchers have found we can get in anemia, and increase the risk of PPH, postpartum hemorrhage, and the perinatal neonatal mortality, low birth weight, and preterm birth are common. Further effects, neurodevelopmental impairment, late fetal and early postnatal period are recognized as a critical period where there is a rapid brain development. Therefore, there can be impairment of the neurodevelopment. At the birth also, low APGAR score can be found, and the impaired motor, cognition, and language development in the neonate can occur. So, in this picture, this you can see the iron is we intake about 1 to 2 milligram, and it through the stomach duodenum, at the duodenum and upper jejunum it get absorbed, and for various mechanisms this iron is used. If there's a fetus, the baby will use that iron, and for the heart muscle and other body muscles, pancreas, and many other tissues, liver, all these organs require iron. In the bone marrow, the erythropoiesis, the red cell generation occurs, and when it destroyed, it is reutilized. That iron is reutilized here via the macrophages and given to the stores. If we consider the symptoms, as I said, the fatigue, dizziness, pale skin, headache, cold hands, shortness of breath, difficulty in concentrating, irritability, insomnia, or sleepiness, everything can be there in iron deficiency. So, when we consider the signs, the brittle nails, sometimes they can have enlarged spleen, and angular stomatitis also can be there, and some people complain of difficulty in swallowing due to the pharyngeal web. So, causes of iron deficiency anemia, blood loss, menstrual or perectal blood loss, and the poor diet, multiparity, medications, inhibitors, that is tea and coffee, the tannins, and the poor absorption, the gut surgery are there. Some people come and ask whether we get poor absorption, some doctors told, but such congenital absorption defects we have not come across or not proven. Maybe there are some substances lacking and poor absorption may be there, but such a proven things we haven't come across. Then, as I said, the iron absorption occurs in the duodenum and in the upper jejunum. So, it's absorbed in the ferrous form, and it needs acidic environment for absorption. If I mention little about pathogenesis, now the iron absorption, not like when we were studying, the hepcidin is found to be a main molecule which regulate iron absorption. When the hepcidin level is high, plasma iron absorption is increased. When the hepcidin level is low, the iron, sorry, I made a mistake. When the hepcidin level is low, the iron level in the body is low and absorption will be helped. It increase the absorption. When the hepcidin level is high, it inhibit all the body mechanisms of related to iron. It will reduce the absorption. It will splenic macrophage degeneration and producing iron will be inhibited, and in the liver Kupffer cell activity inhibited. All these will be inhibited by the hepcidin molecule. So when the hepcidin is high, the iron absorption will be limited and this mechanism will go on. So this is the novel iron metabolism controlling mechanism. So here I talk about it a little more. Hepcidin is the hemostatic regulator of the body iron absorption, distribution and metabolism. Circulating hepcidin is suppressed during iron deficiency. Then the iron absorption is promoted actually. Anemia and increased erythropoiesis, the amount of hepcidin are increased by high level of iron in serum and liver and during infection and inflammation. By integrating these competing signals, a low amount of hepcidin indicates when the body is iron deficient and will efficiently absorb iron. Conversely, raised amount of hepcidin would block duodenal iron absorption. So now in iron deficiency, what are the investigations? The most basic and common investigation is the full blood count. And here the MCV, MCH, MCHC will be low as we know from our MBBS period. All three will be low. But in thalassemia carrier state, which is always confusing with the iron deficiency, MCHC will be normal, mostly normal, but we cannot diagnose completely by looking at these figures because there are so many other factors interfering. Physiologically, in pregnancy, MCV increases about 6 femtoliters. So that will mask the condition because you will see like not the actual MCV, slightly higher MCV. Therefore, thalassemia and iron deficiency one can mix up. So other than that, the iron studies, the serum iron will be low, total iron binding capacity is high, and saturation will be low. But according to the guidelines, these are not much used in pregnancy because these can interfere with many other factors, the dietary iron, the iron intake, the oral iron tablets, these can be interfered. So the serum ferritin is fairly alright, but still that is also acute phase reactant. But if it is less than 30, it's considered it's as iron deficiency. This is the cutoff. Even all the hematologists also consider less than 30 considered as iron deficiency. But it can go up. Always we have to keep it in our mind. It can go up during acute phase. So CRP, if you suspect fever or some other acute event, better to do CRP and get the correct idea. The next investigation is blood picture. It is very informative. You can see here severe iron deficiency anemia patients, the pencil cells and the very hypochromic picture. And it actually thalassemia, if the picture preparation is very good and if the laboratory sample is fresh, we can identify thalassemia from iron deficiency by looking at the blood picture, because in thalassemia we can see basophilic stippling, target cells, and it's like rich kind of a picture in thalassemia. But mostly the preparations, the EDTA samples are coming from faraway hospitals and the preparations not that satisfactory, therefore it's not definitely mentioned. So bone marrow iron is the best iron estimation, but we, as it's an invasive investigation, we are not supposed to do to assess the iron level. So other investigations to rule out the cause, as the anemia is a symptom, we have to do all the other relevant investigations: ultrasound scan, laparoscopy, stools for gallbladder, endoscopies, depending on the situation. But in practice, we have found mostly the childbearing age, the ladies are having anemia because of the increased menstrual bleeding. They may not say, but when you ask several times, it's that. Other thing is the urine. Urine full report might show red cell urine or hemoglobin in urine. And the urine hemosiderin also important in chronic hemolytic anemias, where the iron is deposited in the epithelial cells of the nephrons, where when they shed urine, we can stain for iron stain, and if it is positive, we say it's urine hemosiderin positive, and that means there's chronic hemoglobin lost through the urine. That is common in PNH, paroxysmal nocturnal hemoglobin and in hemolytic anemias. So further, the investigations, these are actually done in research levels, not available in Sri Lanka, but I have to mention them. Soluble transferrin receptor levels, reticulocyte hemoglobin content, this is very useful in renal disease, and serum hepcidin, what I mentioned you earlier, hepcidin. Actually now they are trying to bring it as a laboratory test to assess the hepcidin level. And in practice, for obstetricians, actually, you can give a trial of iron. It's mentioned in the guidelines, and review in 2 weeks. And if there's a response, you can guess that this is iron deficiency. But current good practice guidelines, ideally, we should do a booking at the booking visit, a basic testing, that's full blood count. Ferritin people may not be able to afford, so at least a full blood count at the booking visit and at 28 weeks. So about the iron prophylaxis, after diagnosis or even before diagnosis, here the indications for empirical iron supplementation. When you see a patient, then and there, without investigating, you should start in these cases, especially when there's previous anemia, when multiparity, multiple pregnancy, twins or triple pregnancy, interpregnancy interval is less than 1 year, poor diet, vegetarians and vegans, teenagers, recent history of bleeding, high risk of bleeding during delivery, and Jehovah's Witness, you should start iron prophylaxis. So when we come to the treatment of iron deficiency, first thing is the dietary advice. As we all know, iron is there in meat and fish, and poultry is absorbed 2 to 3 times more readily than non-heme iron. Absorption is because the heme iron is there, direct absorption occurs through the gut as the heme iron, not through the other mechanisms. Therefore, meat and fish is the best. There are also red meat, red fish is better. And the vitamin C enhances iron absorption from only in non-heme foods. That's green leaves, other sources of iron, not the heme iron. But for other heme, iron will be absorbed when the vitamin C, the acidic environment is available. And the tannins, the tea and coffee, inhibit iron absorption, especially when it's taken with your meal or just after or short while later. But after 2 hours after, they can take tea, so we shouldn't strict on that. Iron replacement, the oral iron is the best, and it's cheap, and the ferrous salts are popular and preferred because ferric is, as I said, should convert to ferrous to get absorbed. Therefore, ferrous preparations are the best. Ideally, for the prophylaxis, 30 to 60 milligram elemental iron is recommended. That is available in the preparations what we use. Even FIFOL, FERAP like things give this prophylaxis dose only. So 100 to 200 milligram elemental iron for treatment dose. Actually, in my practice, I even go little higher, like 300 3 times a day. Then very quick response we can see, but little bit the side effects are little more. But the recommendation is 100 to 200. So we can use a tablet which is available in the market, which contains elemental iron 100 twice a day or 3 times even. No harm if the patient can tolerate. Ferrous fumarate, ferrous sulfate, and ferrous gluconate are the preparations available. So, side effects are more with higher doses. Hepcidin levels are lowest in the morning in anybody. Therefore, suggest to take a morning dose, preferably empty stomach, but very difficult. We shouldn't go behind that. Very difficult. They cannot tolerate. What I say usually, the 2 hours they can't tolerate after taking the tablet. They can take the tablet and eat a small thing like whatever they like, chocolate or something, and wait for some time and then have their meal, and it works well. So optimum dose, the ultimate recent guideline estimated dose elemental iron, they say even 40 to 80 milligram every morning is adequate for the treatment. Slow releasing enteric coated preparations may pass through the duodenum and it might not get absorbed. So the once hemoglobin is normal, still you have to continue iron further. Do not stop it by looking at the hemoglobin level. Actually, what we do, the ferritin 75 to 100 nanograms per ml should reach to stop the iron level, iron taking. So if they are taking lower dose, it should take another 3 months to replenish the iron stores. At least until 6 weeks postpartum, one should take iron to replenish the iron stores. Constipation and diarrhea should address accordingly. They can use the constipation treatment what we usually use. For diarrhea, of course, it's not heavy diarrhea, so we can reassure them. With time, it goes off. Nausea, vomiting, dark color stools are common. And we have to tell about the dark color stools because excess iron is like tar, they pass. And repeat hemoglobin in 3 weeks to 1 month. Practically 1 month is easy, but in guideline it says 3 weeks to assess the improvement. Then we should consider IV iron therapy, but for those who are having non-compliance, intolerance, when there's malabsorption, when a rapid hemoglobin response is required, because IV iron is giving rapid response. So we should avoid IV iron when there's history of anaphylaxis, common anaphylaxis. Even our practice we see them getting anaphylaxis. So we should prevent either, and allergic history better not to give. And the guideline also say not to use IV iron in first trimester because anaphylaxis is fatal. That's the reason for that. And when there's a bacterial inflammation, IV iron utilization is inhibited because of the cytokines and various interleukins released by the inflammation. And iron sucrose is the preferred preparation. But there's a disadvantage in iron sucrose, that is we have to use multiple infusions. Ideally, we can use 2 vials, that is 10 ml, once daily infusion only in 200 ml normal saline. Preferably, we always pre-medicate them. It is harmless with hydrocortisone 100 and Piriton 10 milligram IV, which might make them drowsy. but it's better to pre-medicate before the iron infusion, and always lower dose initially and then increase the rate of infusion. Actually the IV iron is very good. The risk of the side effects are very low, and anaphylaxis risk, skin staining. If the IV drip goes out, skin staining can be there. Iron carboxymaltose, it's a very good substance, still not available in Sri Lanka. And iron isomaltoside is another substance, single dose and very low side effects. I think it's available in India and it might come here soon. Now I'll move to B12 deficiency. This is actually earlier, now it's getting back again. We see now about one patient a day, because of the cost of meat and fish. B12 available only in animal food, meat and fish. So, but it's produced in the gut, a small amount produced in the gut by bacteria. Therefore, some people can manage with that amount. Pregnancy, if we don't give the supplements, there's reduction of cobalamin levels by 30% by the end of the third trimester. So they can go into deficiency. What are the clinical features? Briefly, anemia, paresthesia, the neurological symptoms, and commonly the mouth ulcers, the mouth pigmentation, dark color patches on the mouth, and dental surgeon usually find out early B12 deficiencies. So the laboratory, we can do the serum B12 level, sometimes not very reliable. Even in deficiency, you may find normal levels. That's described in articles. And full blood count, blood picture will show high MCV, oval macrocytes, hypersegmented neutrophils. I have shown it here. Hypersegmented neutrophils and the oval macrocytes. Bone marrow can be done, but as the B12 levels, if it's low and it's straightforward, we are not going for invasive investigations now. So the treatment of B12 deficiency, oral preparations are now available. Some preparations in the market has high level of B12, 1000 to 1500 micrograms, and intramuscular 1 ml, that's 1000 micrograms IM, twice per week for 6 to 10 doses we should give. And the intermittent top-up doses if the patient is a vegetarian. And we have to always in B12 deficiency look for the etiology, maybe the vegetarian or autoimmune, intrinsic factor antibody assay, parietal cell antibody assay, like things rare in Sri Lanka, but in other countries it's common. Bowel surgery, drugs like omeprazole, metformin, they say it inhibits the B12 because of the alkaline environment of the gut. It inhibits the absorption. So the folic acid, it's actually freely available in green leaves and fruits. So nuts, it's easily we can take, and daily folic acid requirement is small, 400 micrograms. It is required for pregnant females before 12 weeks of gestation to reduce the incidence of neural tube defects. Now the 1 milligram tablets are available, but not necessary to give 5 milligram. 5 milligram means 5 tablets. We should give proven folic acid deficiency in severe cases only. Otherwise, 1 milligram means 2.5 doses are given. So 50% stored in the liver. For 3 months, storage is there in the liver of the folic acid. So excess folic acid we take will be excreted in the urine, therefore no harm. Serum folate level and red cell folate levels are the investigations we can do, but the red cell folate give you the lifetime folate estimation, not current folate level you can see from serum folate level. Now I move to the thalassemia, the micro nutrients, no time to discuss all that. So thalassemia, if I talk about now, beta and alpha are two thalassemias prevalent in Sri Lanka. So I have mentioned here, alpha thalassemia is not a major health problem. Therefore, we mainly concentrate on beta thalassemia. Alpha thalassemia, we have 4 genes in our chromosome. As there's 4 genes, it's not necessarily they do not get much symptoms. All 3 genes should delete to get symptoms. It's very rare. Therefore, it's not a social problem. But beta, we have 2 genes only, one from mother, one from father. You can see here this couple, green one is normal, red one is diseased one, and both are carriers. So they will produce green one is the diseased one. You can see a offspring of thalassemia major, chance is 25% and 50% chance of getting carrier children, and normal child also can get, it's a chance. So if the only one parent is carrier, there's a 50% chance of getting carrier children, others are normal. So it doesn't matter. Even some we have about 4% people with thalassemia gene, and all big post having people are having thalassemia gene. So it doesn't matter. Anybody can live with it, no issue. So alpha gene, so the beta problem in pregnancy is due to dilutional anemia. Otherwise, they will go unnoticed. But with the dilutional anemia and the existing anemia, they get symptomatic and less hemoglobin level. If the hemoglobin level is less than 7, we have to think of blood transfusions. And if they are symptomatic, at delivery, for anesthesia and risk of bleeding, we can think of transfusions. Otherwise, regular transfusions not required if they are not symptomatic. You can always see the patient's mother also had it, and she even doesn't know about this condition. But if they are symptomatic, we have to think of it. So mild, and usually the carriers are the problem in gynecology and obstetric. So the mild anemia, they have 9 to 12 and hypochromic microcytic anemia, and they might give a family history. Serum ferritin should be done in that case to differentiate from iron deficiency and to consider iron replacement if necessary. Mostly, our ladies mostly have iron deficiency and thalassemia together. Then we should think of iron replacement. Some doesn't take. They say, doctor has told me not to take iron, so I shouldn't take. But if they have iron deficiency, if the ferritin level less than 30, they should take iron to bring it up to 75 or 100. Essential to check partner for thalassemia carrier state. Because we can only do full blood count and blood picture initially. If necessary, go for other investigations. And we should plan when we catch them family screening. And baby screening preferably should be done 6 months later, because they have fetal hemoglobin up to 6 months, which will difficult in interpreting the HPLC and electrophoresis because of the fetal hemoglobin. So if it is essential, we can do, but otherwise we prefer them coming after 6 months. So hemoglobinopathies are the other kind of, we call them not the thalassemia, hemoglobinopathies, diseased hemoglobin. That is due to mutations in the globin chain. Heme and globin, the globin chain has mutated hemoglobin globin chain. So HbS is in sickle cell anemia and needs specialized care during delivery, before and after, to protect their lives if they are sickle cell. HbE, D and many other mutations of globin chain are found. So what are the investigations we should do in thalassemia and hemoglobinopathies? For both, full blood count, serum ferritin, blood picture, HPLC, high performance liquid chromatography, or electrophoresis. Ideally, in now America and those countries, they do all the available, because they say some bands are hiding inside the A band. Therefore, they do all the available electrophoresis, HPLC, capillary electrophoresis, all that in screening. But here we do HPLC, which is actually for beta sorter, for the beta thalassemia only designed, but it can catch sickle, E of course overlapping with the A2, but fairly useful. Electrophoresis is a bit difficult, crude, but capillary electrophoresis is the best. It's available in most of our hospitals, but very expensive now. After the COVID, the reagent cost is very high for capillary electrophoresis. Right. Few more things. Hemolytic anemia, autoimmune hemolysis. Now, these are not common, rare, but you may come across unsorted anemia. In that case, we should go for this kind of simple investigations. Must think of autoimmune hemolysis. Cold and warm types are there. They can have hemolysis when they exposed to cold environment because of the antibodies, autoimmune antibodies produced against the red cells. So they bind to the red cells and they damage inside the spleen. So they could be asymptomatic when they are young, but when little anemia. But when they get older, they get acute hemolysis. But in acute event like pregnancy, they might get acute hemolysis. So they may show you jaundice, pallor. Then we should concentrate on full blood count anemia. Sometimes they have low platelet, high MCV, unusually high MCV in the analyzer, 120, 130, like that, right? And indirect bilirubin will be high. Blood picture might show auto-agglutination, and direct Coombs test is very important. Here it is positive. The antibodies will be demonstrated by the direct Coombs test. But we should send this investigation before blood transfusion. At least if it's urgent, you must tell the nurses to keep few samples in the fridge, take extra in case to use for such investigations after transfusion. LDH level will be high, but we can get mislead. LDH also can go high with liver disease, hemolysis, like conditions, even acute inflammatory conditions. ANA also useful here. So in this case, special care is necessary. So anemia of chronic disease is another rare condition you may come across in SLE, rheumatoid arthritis, chronic diabetes, and renal disease. So most of now our mothers are sometimes elderly. These kind of things are common. Usually normocytic normochromic anemia in anemia of chronic disease. Sometimes some show hypochromic anemia. So they are the serum ferritin level is normal. High ESR can be seen. ANA and other rheumatoid factor, creatinine, and other special investigations should be done. Then the bone marrow failure is a rare. Aplastic anemia can occur during pregnancy. Aplastic anemia, some people present with low counts during pregnancy induced aplastic anemia. We had some patients and they delivered nicely with drugs, cyclosporin like drugs, only that drug. Some we can treat actually. If it is immune mediated, they will respond to that treatment very well. And the myelodysplastic syndrome is a disease of old age, but it can be seen sometimes in younger people. These people may need blood transfusions and special treatment like cyclosporin, etc. Even bone marrow transplant, which is not available for us readily. Right. So other kinds of anemia we have to think of. Even hypothyroidism can cause anemia, mild anemia, usually macrocytic anemia or normocytic normocron. Infections, chronic wounds, chronic inflammation, and those things causes anemia because of the iron and other nutrient absorption, metabolism all inhibited. Dilutional anemia is sometimes more than expected for some ladies. In that case, if we do, after doing all the possible investigations, the basic investigation, we can come to a conclusion this is dilutional anemia, and they will be taking iron supplements, sometimes high dose iron, expecting a good value. So, all above cause mild anemia, and serum ferritin may not be helpful in anemia of chronic disease when the infection and inflammation is there. So, about just a few things about erythropoietin. In pregnancy, we do not use erythropoietin commonly, but even for other conditions, you can think of it. Erythropoietin is a new agent, not new actually, treatment of anemia in following situations. Erythropoietin deficient anemia is very rare. You can do the erythropoietin level to detect such thing. And severe progressing iron deficiency anemia. If they are not responding at all, you can give a shot of erythropoietin. But always ferritin should be normal to use erythropoietin. If there's no iron stores, they cannot produce red cells if the iron is depleted. So always either we have to combine with iron or we give IV iron before starting erythropoietin. And for the patients with Jehovah's Witness, those who refuse blood transfusions, and placenta previa patients, pre-operative and post-operative patients, and autologous blood transfusion requesting patients, you can consider these in new society if such requests are available. Then, pre-malignant and malignant conditions, we have other hematological conditions, polycythemia, but the hemoglobin is high. If when we are treating, they get anemic. And essential thrombocythemia, high platelet count. Lot of young people now coming with this because of the laboratory and the investigations are readily available. We detect them early. And myelofibrosis like conditions. Then acute leukemia, AML, ALL, chronic leukemia. Sometimes even we have this kind of chronic leukemia patients with pregnant. Chronic granulocytic leukemia, chronic lymphocytic leukemia, they can go ahead with the pregnancy with alternative drugs, interferon-like drugs we can use and control the counts, and they can have children. And lymphoma-like conditions. Thank you very much. Okay.
Stay on the stage. We have some questions. Yeah. So we had one question while you were delivering the presentation, but I think you gave the answer to it. Is there a diurnal variation of hepcidin?
Yeah.
At what time of the day it's better to take oral iron?
Yeah, oral iron should be taken in the morning. As we said, the hepcidin level is low in the morning.
Right. Then the next question comes. It says, what is the infusion rate of iron sucrose and the duration of treatment?
Yeah, actually initially what we practice, first half an hour, 10 drops per minute. That's very low, slowly. And you look for the reactions, whether they develop any reaction, allergy, itching, increased heart rate. If there's no such thing, we can increase the rate. But the thing is, even if we increase, it's thick solution and it will take some more time. We can give rapidly, no harm, but it won't go fast because it's a thick solution. Viscosity is high.
What about the duration of treatment?
You mean, right.
Okay.
Yeah, usually we expect now say the hemoglobin level is 8, we expect 1 gram increment from one dose. That is 200 milligram they take if 2 vials are given. That is 5 ml in each vial, 5 ml into 2, usually 200 mg. So that will expect to increase by 1. So that's how there's a calculation in the leaflet also. Usually if it's 8, you need up to 12, we have to give 4 doses. Even daily, if the patient is admitted, you can give daily, no harm. But if they are coming from home, you can give even weekly, depend on your requirement. Very urgent increment, you can give quickly, otherwise weekly, no harm.
Right. Another audience member has asked a similar question. After IV iron, how long should we wait to start oral iron?
No, there's nothing like that. IV iron is there in the body. They can continue as usual because it's 200 mg. I said even up to 300 we give oral iron, then we don't have to load another 300. You can give once daily. Or the patient may not like anyway. You can wait for few days. There's no hard and fast rule like waiting.
Is there any, this is a question from me, is there any harm in giving IV and oral at the same time? Because generally we
no
have an
harm.
understanding that we should stop oral iron while we give administer.
Madam, is there such a thing?
That's,
All filled, that's what they think.
okay. So we can
But
give both.
absorption will take time and
generally we give intravenous iron only in people who cannot tolerate oral iron.
yeah.
Unless you want it in a hurry. So generally intravenous iron will correct the deficiency.
No, that depend on the amount we give. If ferritin is iron stores, now they say IV iron will not rapidly increase, but it's faster. It might take 1 or 2 months to fill up the ferritin stores. Or maybe we are giving inadequate infusions because it's IV, patient has to get admitted. To fill up the ferritin, we have to give more doses. No, we were talking about 1 gram increment, and to fill up the ferritin we have to give more doses, and oral iron if they can take, it's better. Yeah. Yeah. Usually we should give 2, that's the leaflet, and 2 vials in saline, but even I have given 3 vials in some situations. No, nothing. Yeah, it doesn't matter. If they can tolerate, no allergies. They feel better. Their appetite, even I saw one patient yesterday, hemoglobin 5, no appetite. They were thinking it's a malignancy, and with the iron 1 infusion, she came, I can eat now. Yeah, they get better.
So I'll quickly run through the rest of the questions because I think these are from the registrars. What is the expected response improvement in hemoglobin level after 2 weeks of IV iron? I think you answered that question. Then in thalassemia trait, when should we consider starting iron supplements?
Yeah.
What about every other day prophylaxis?
Always they should do the serum ferritin level in thalassemia trait. And if it's less than 30, you mean the prophylaxis?
Yes.
We tell always give low dose prophylaxis if the ferritin level is less than 100. Because fetus need iron and she become deficient otherwise. If it is more than 100, say 300, 400, don't give. But you repeat serum ferritin maybe in 2-3 months time and check the ferritin level. Check the ferritin level. If it is depleting, you start again prophylaxis.
One question.
Yeah.
Now we give all the patient iron, all over the Sri Lanka.
Yeah.
My question is, do you have to go for all the patients iron?
I,
Sorry. We give all patients iron in our clinics.
yeah, we give iron for all the patients.
Yeah. Do we have to give that?
In Sri Lanka, actually, we said actually more than 30%. Most of our ladies are iron deficient.
Now, since we are doing it at the moment because we are medical registrars, we couldn't do the hemoglobin levels.
Yeah.
Since we are doing hemoglobins, I have seen even hemoglobin 13, we are giving hemoglobins. Iron.
So that's what they say. At the booking visit, we should do a full blood count. If at that time they are very early, MCV has not changed and they have, then the indices may be lower. MCV, MCH, MCH. Then they are definitely deficient. But normal people, if they have normal indices, MCV, MCH, MCH, they will deplete iron while during pregnancy because fetus take lot of iron.
Yeah, but my question is, if you are doing, because normally we do hemoglobins, if they more than 11, do we have to give iron for them?
Better to do ferritin.
Ferritin, okay. Ferritin is normal?
So what?
Ferritin is normal?
Ferritin normal means actually there's a problem in our reports. They give the value 5 to 140 normal. That is not the level we should follow. Less than 30 low, but if it is 100, you don't have to give. But you have to repeat in 2 months or so to see whether she has depleted.
Personally, I feel because we are giving to every each person iron.
Yeah.
Even I have seen 13, even hemoglobin 13, we are giving at the third trimester.
So ferritin level is if they can afford, no harm.
So if you give 13 hemoglobin, you can't go by hemoglobin.
30.
You can't go by hemoglobin levels.
Hemoglobin, no. Sometimes they are hemoglobin 13, but ferritin low, 4 like. And MCV, MCH normal. We have found so many. They will soon go into iron deficiency.
Yeah, but I'm saying is that trimester.
Iron stores are depleted. That's the sequence. First the stores will deplete, then the MCV, MCH changes, the hemoglobin drops.
In our setup here.
Yeah.
But in foreign countries, they don't give iron supplements.
The prevalence is very low. In UK, 0. Like I went through the data. Yeah.
Here 30%.
Yeah, 30, more than 30 actually. Yeah, in Colombo, Ragam area, we can say 30-40. When we working in Ratnapura, that area, very high. Almost all are deficient.
Okay, thank you.
Yeah.
If you get a chance, I think you will get a chance to correct this. When we were working under our consultants, the 5 milligram folic acid was available.
5 milligram?
5 milligram folic acid was
not available. Now,
available in the early available in the market.
Yeah, earlier.
Because then one point, I know the point also, it was stopped bringing and banned that level and started getting down to 1 milligram. Now the science has improved and now we need therapeutic levels of folic acid.
Yeah.
If you get a chance and if you are attending that type of meeting, please get down 5 milligram, especially thalassemias. Thalassemias, now we start 10 milligram folic acid from the beginning.
Really?
Yes.
But you can give 1 milligram BDO, isn't it enough?
Right?
Yeah,
5
that's
tablets.
enough. No need.
Right?
That's what I especially mentioned that because I have seen my colleagues also giving 5 milligrams.
Yeah. And those who are in the anti-epileptics, we need high doses.
But
anti-epileptics.
Anti-epileptic. But then, no madam, because daily requirement is 400 micrograms. So
Right.
one tablet has twice half, 2.5 times,
Then why
5 times. Then
why
if
they
you be
recommend now even diabetics? We were asked to give high doses of
uh,
folic acid.
yeah, but WHO only changed this about 6-7 years ago because 5 is too much. That's what they say. It's given only for severe folic acid deficiency. Now we are here giving for prophylaxis, no? So that is 1 milligram enough. For
Enough.
required people, you can repeat. See, 1 TDS. Yeah.
Yeah. Yes.
Mm.
And because recently the guidelines, even diabetics, high doses,
Mm-hmm.
thalassemia, I have seen your colleagues are
No,
using high
enough.
doses.
But
And then we have a problem. Patients come and ask how to swallow 10 tablets.
that's the thing. Can't swallow.
Yeah. Right. And the other,
But it's
and there is another thing.
mm. Okay. But 5 milligram now not available.
No, it was stopped.
No,
getting
no,
out
not in Sri Lanka, in the world.
in the world.
Yeah, because it's not essential, they say.
Ah,
5
right.
times now by because liver also has stores for 3 months. Lot of folic acid stored in the liver. B12 also same. For 3 years it's stored.
Right. And another thing is in the now,
You can say TDS, 1 milligram 3 times a day.
then there's another thing in our preventive sector, because of the tolerability, we are advising iron to take in the night.
Yeah, that's fine. But
It's
always
not
better to take before meals because
Yeah.
pregnant ladies, the stomach pressed and it's coming always upwards. So tell them to take before meals and take glass of water, plantain or something, some good, so if it comes up, some good smell coming food and then take their meal. I always tell not to wait half an hour, 2 hours, but the pharmacist always tell them to wait for 2 hours.
No, that
and
is
they
because of the
books.
MOHS.
Right.
It has to be
They
corrected
say.
at the familial bureau level.
Yeah, that's the actual practice. Even guidelines says take 2 hours before. So we can't. This is our practical thing, no. I don't know how legal it is.
Yeah, there are a few more questions. We'll have to run through them. How do we calculate IV iron dose? I think you touched that. When do you think an obstetrician should refer otherwise all right anemic antenatal mothers to another specialty, and whom?
Yeah. Anemia, of course, the hematologist you have to refer. Otherwise, various things can happen. Even we don't go for invasive things unless it's essential. And when the anemia, if you can correct mild, even moderate anemia, if you can correct, no harm. But severe anemia, definitely you have to refer to find out the cause, especially. If there's underlying etiology, we have to treat it.
Okay, thank you. And more questions coming through. Can you roughly tell the cost of some tests like HPLC, hemoglobin?
HPLC now available for outside 6,500, and capillary electrophoresis expensive, not available in the private sector. It came to 16,000, so they closed the machines. But in government sector, capillary is available. It is the best thing is it is calibrated for all the available abnormal hemoglobins. You can get the peak in capillary electrophoresis. MRI, it's available in our this thing also.
And then folate levels?
Folate levels expensive. Even I don't know.
Right. After blood transfusion, can we give IV iron to restore iron stores? Do we need to wait any time?
No. If there's no allergy after blood transfusion, usually they get itching and all. No. You can give Dr. Dodampal, Professor Dodampal told now. He's giving it.
I think this was also addressed. Shouldn't we give iron to all mothers irrespective of hemoglobin and normal ferritin?
Normal ferritin depend on the ferritin level. They can deplete, as we discussed. With time, it can deplete. The fetus uses lot of iron. It need lot of iron, myoglobin for various things. Therefore, we have to can avoid, but you have to keep an eye about the ferritin level. If it comes lowering like 50, better to start prophylaxis.
Another question, madam, if calculated IV iron need is 600 milligrams, can we give daily 200 milligrams or should we give every other day?
Yeah, depend on the patient's situation. If she is involved and if urgent improvement necessary, daily you can give. Even we have used that. But if she is coming from home, you can better to have a break.
They also want a simple algorithm like total, I can't read this question, XY investigation and refer. So they just want an algorithm in case of anemia, what investigation should we do and then when to refer, I suppose.
Definitely full blood count. They have to do serum ferritin, blood picture to see what with the autoagglutination and things. Those are basic ones. So depending on that, they should go. If ferritin normal, still hypochromic, then go for HPLC, like that. Yeah, blood pictures.
Again, the same question is coming up. I'm not sure that it was not clear. When do you think an obstetrician should refer an otherwise all right anemic antenatal mother to another specialty and to whom?
Yeah.
I think you answered that.
Yeah. If they don't find improvement after giving iron, they should definitely refer. Right.
Yeah, about this folic acid, the Royal College guidelines say that for obese women where the BMI is more than 30, for type 2 diabetics, so pre-existing diabetics, that we should be starting giving preconception 5 milligram folic acid. So that is
right.
the RCOG guideline. Also, in addition to that, of course, in the secondary prevention of neural tube defects.
So it's available. If
we
it is
struggle
available, we
with the
can
dose.
order.
Yeah.
Okay. Right.
Thank you.
Thank you very much.
Thank you very much, Dr. Visakaratna Malala, for your interesting talk on the journey of hemoglobin in pregnancy and, of course, for taking so many questions from the audience. We now have the next lecture for today by Dr. Dimuthu Muthukuda on thyroid disorders in pregnancy. She will be presenting as a case-based discussion. To introduce Dr. Dimuthu Muthukuda, she's a consultant endocrinologist attached to Sri Jayawardhanapura General Hospital. She is also the president of the Sri Lanka College of Endocrinologists. She obtained her MBBS from the University of Colombo and an MD in endocrinology from the Postgraduate Institute of Medicine, University of Colombo. Dr. Muthukuda is a member of the Royal College of Physicians in the UK and a fellow of the Sri Lanka College of Endocrinologists. Over to you.
Thank you, Shamoon. So first of all, I would like to thank Professor Duram Pahala, the president of the college, and Shamoon for inviting me. So thyroid disease, as you all know, is a very complex condition. So the case detection itself is very complicated, and utilization of investigations, diagnosis, and treatment, like all are very highly complex, and a lot of controversies exist. And clinicians have been, having sort of a debate, and also there's an ongoing debate on this entity. So it's fully worth, I think, looking at this subject. And so although Shamoon said that it's going to be a case-based discussion, yes, I'm planning to show cases, but I thought it's better to address on the little bit about the background aspects as well. So first of all, I would like to show these scenarios, but all these are hypothetical ones. I think what I've done was that I've tried to address, to show the entire spectrum of thyroid disorders that one could encounter. Those who are listening online, so please go through these cases. I've tried to tabulate everything. And we just don't concentrate that much on the basic, the personal details, but look at the trimester and, TSH, free T4, T3, so there's just one value of T3 and the TRAB, TPO antibody and TRAB. So I think at the end of the presentation, we'll try to come back to this slide and we'll see whether we could understand what this is all about. So I'll give a couple of seconds for you to go through the cases. So everything possible I've tried to incorporate into this slide. Shall I go to the next slide, Shamoon? Okay. So now we have seen what the spectrum, how vast the range of thyroid disorders could be. So now, how can we do how is the case detection done? So that's the question. Are we supposed to do universal screening or is it just targeted screening? So one against the other. Now we know that in Javadanapura Hospital, Shamoon and Dr. Madhava, both are there. So we do universal screening. So in every single pregnant mother, we do the TSH. So that happens at Javadanapura. But of course, we cannot generalize that, this being a semi-governmental hospital, we cannot simply generalize that to the entire country. So the outline of the talk would be this. Now, so what was the reasons? What were the factors that paved the way to this, the complexity or the controversies? Now, so there was this pivotal publication in 1999, so which discussed the association between hypothyroidism, which was diagnosed at 15 to 18 weeks, and the associated decreased IQ at 7 to 9 years of age. So that was a very significant association which was shown in 1999. So that was the time where this, the stirring up of, which stirred up the debate. That was the start of the debate. That was back in 1999. And also, it showed that mothers who received thyroxine while pregnant showed only a minor deficit in IQ. So, mind you, that was overt hypothyroidism. And a little bit about targeted screening. So, this method operates on 3 principles. Let's just look at the principles. It's just common sense. So those are the principles which should guide this concept of targeted screening. And the 2017 American Thyroid Association guidelines, so they have discussed about the risks, the risk indicators. So all these actions we know, let's just go through the risk factors. So targeted screening means if these risk factors are there, we can look for existing thyroid disease. So that's the basis of doing targeted screening. So just go through the risk factors. And so what are the concepts? When it comes to universal screening as opposed to targeted screening. Now, so there are 10 principles. These are considered as the gold standard for evaluating a screening strategy which is used as universal screening. So again, it's very easy to understand. Just quickly go through these 10 principles, which are the gold standard criteria of this, the universal screening. So which is used for any particular condition. So, when it comes to, let's look at now, this is the forum of, we have gynecologists, obstetricians here. So it's very I mean, it's very practical if we look at antenatal screening. So we do various tests as universally. Now, for example, we screen for gestational diabetes. Now, outside Sri Lanka, in other countries, most developed countries and maybe in some regional countries, we screen for GDM only in high-risk mothers. But in Sri Lanka, we do universal screening based on the principle that all of us are high-risk women. Being a South Asian itself, that makes us being at high risk. So lot of conditions. Now, for example, we screen for congenital hypothyroidism. So that's done universally. So, one would question, why it's just a matter of, taking some additional blood for TSH. So why can't we screen for thyroid disease in pregnancy by doing one additional blood sample? Since we are looking for various other conditions universally. So that's just a thought. So let's discuss about the applicability to thyroid disease in pregnancy. So when it comes to universal screenings, is it rational looking for thyroid disease in every single mother? We have to look at it from different perspectives. Is it actually indicated? And it's not just that, is it practical? So these are, both these things are important. So let's look at what happens to the thyroid functions in pregnancy. So when you look at the graph, you will realize that how complicated this is. This is one reason. This is actually the main reason why it has become very complex. Because of the physiological alterations that takes place during pregnancy. So what happens to TSH? So you all know, due to the HCG effect, TSH drops, especially during the first trimester. Look at the graph. TSH drops during early pregnancy, and towards the latter part of pregnancy, it will come back to the normal level. So what happens to free T4? Free T4 tends to be a little higher than compared with the outside levels in the early, late T1, first trimester, and then, gradually it will come down, and towards the second and the third trimesters, it will drop a little bit. So that's the behavior of free T4. So free T3 also, the same thing you would see. And total T4, total T3, so just when you look at it, you will understand, so the levels will be higher because it will be in parallel with the binding globulins, so you tend to get high levels. But nowadays we don't do total T4 levels, we go by free T4 levels. And okay, so those, I think it's you all should be able to understand when you look at the graph. So that's how the thyroid function tests behave during pregnancy. So just look at these pie charts I've taken from a very recent article published by an Indian author. So this shows the spectrum of thyroid disease in pregnancy. So I've listed those out. We have overt disease, overt hypo, overt hyper, and we have subclinical disease, subclinical hyper, subclinical hypo. And there's another condition which is almost unique to pregnancy, so that's called isolated hypothyroxanemia. And then we have another entity, because nowadays we have easy access to thyroid antibodies, and there are women who have antibody positivity with normal thyroid functions, euthyroid women with positive antibodies. So this shows the entire spectrum of thyroid disease that we see in pregnancy. So, determining prevalence is complex. Why? Because, thyroid function tests are altered, and that itself is, makes it very complicated. So, and also, depending on the trimester also, these test results, they are altered. First trimester, second, third, if you take one individual mother, it's sort of a dynamic thing. When you go along the pregnancy, things would change. And also we know that we have to go by population based. trimester specific reference values. I mean, it's not just when you have a report, you are not supposed to compare, you are not supposed to interpret, looking at the reference ranges that are given in the report. I mean, which are meant for people, outside pregnancy. So ideally speaking, you need population based, trimester specific and assay dependent laboratory specific reference values for you to interpret these thyroid function tests accurately. So you'll understand, how complex this the entity is. So this is another very interesting article. It shows that the diagnostic criteria is very confusing, and the disease spectrum. I mean, it's just a spectrum, mind you. I mean, you really cannot compartmentalize these different conditions. So I mean, this systematic review and the meta-analysis, it had shown that the vagueness of the criteria had made it very difficult to determine the true prevalence of thyroid disease in the population. So it's very important. I mean, just look at these prevalence data, then you will realize that, I mean, it's not that uncommon when you look at these figures. So overt hypo, just see the prevalence 0.5%. Overt hyper and subclinicals, it's quite, I mean, we could say that it's not that uncommon when you look at subclinical hypo and hyper. And even isolated hypothyroxanemia in pregnancy, it's nearly 2%. And antibody positivity being euthyroid, so look at the prevalence. But worldwide, from region to region, the prevalence might differ. But I mean, we could say that, I mean, it's a very important conditions which we need to understand. So this is some local regional data. This article had been published by an Indian group of researchers, and when you compare these values with the previous values which I showed earlier, the prevalence is much higher in these populations. So I mean, we are in the same region, so we don't have our own data, but because I mean, I've said that, I mean, depending on the region, I mean, the prevalence could, differ. So this is some evidence for that. So what are the fetal and maternal outcomes? So, I mean, we know that during early gestations, fetus mainly relies on maternal thyroxine delivery. And so during this the period of critical development, where this neurodevelopment takes place, it's very crucial that the maternal euthyroidism is maintained, because the fetus is fully dependent on the maternal thyroxine. And as we know that, I mean, this is like very obvious, untreated overt hypothyroidism, we have maternal and fetal adverse consequences. So I'm not going to go into details, like, so all of us know that. So there are adverse effects on the mother and the fetus due to untreated overt hypothyroidism. So I've quoted, so let's move on to subclinical hypothyroidism. So earlier I showed overt hypothyroidism. Here we have conflicting data when it comes to subclinical hypothyroidism. Certain studies have shown that, okay, yes, there are significant associations between untreated subclinical hypo and affecting the maternal and fetal outcome, and some of the studies have not shown any clear association. So it's very conflicting data we've got here. And what about isolated hypothyroxanemia? So in our day-to-day practice, we do see these mothers with this condition. So again, it's like divided opinion. So, some people have shown that, certain studies have shown that, okay, there is an association, and as opposed to that, it's very vague. The association, unlike what we have seen with overt hypothyroidism. So what do these have taken Okay, so what do current recommendations say about these conditions? Now, I've taken this is just a, the review draft, a very recent article, yet to be published, I think, because you all must have seen this. So they say that universal testing for thyroid dysfunction during pregnancy is not recommended. So taking into considerations all the data available, so that is the most recent recommendation by RCOG. So what do according to the American Thyroid Associations, but this was published in 2017. So they also say that there is insufficient evidence to recommend for or against universal screening. Okay, now there are a few countries, like Poland is one country, Spain is another country, and also in China, they do practice universal screening for thyroid disease. Okay, this is from Spain, so they say that it's justified. Okay, now universal screening in diverse settings. So what are the things that we need to consider? Okay, I mean, it's good. I mean, just like what we do at Jayawardhanapura Hospital, I mean, it's good if we can do this nationally, but we have to look at the economic models. I mean, based on, so we have to actually, some countries have conducted cost-effective analysis. We have to look at, scientific evidence, existing guidelines, and in a country like ours, like where we have free healthcare to all. So you can, I mean, in state sector hospitals, you can do, I mean, very easily TS at 3, T4, but I mean, here the thing is that the actual cost is hidden. So you have to be very careful when you are trying to implement these things. I mean, on a universal basis. Okay, so I mean, we can say that we can come to the conclusion that this, I mean, continues to be a debatable topic. Okay, so now what is the basis? Like, if we are to do universal screening for thyroid disease in pregnancies, can we reason this out? Logically, can we give reasons why we should do universal screening for thyroid disease? Now, when it comes to subclinical disease, so what we need to understand is that, we can consider our own population as well. I mean, we know that in 1995, universal iodization program was started. And after that, we have seen that, and certain studies had been carried out showing that the population antibody positivity, antibody means thyroid peroxidase antibody positivity, had gone up. So it was postulated that it could be due to over-iodization. And at present, our antibody positivity is quite high. So which means that the tendency to develop subclinical hypothyroidism due to Hashimoto's thyroiditis, it should be much higher than what it was some time ago, especially the prior to the iodization program. So on that basis, we can argue, saying that the percentage of women with undiagnosed subclinical hypothyroidism should be significantly high. So that's one logical answer to the question. And on the other hand, as we know that, even outside pregnancies, whether to treat subclinical hypothyroidism or not, it's not clear, even outside pregnancy. So if we are to do screening, if you have to diagnose subclinical hypothyroidism during pregnancy, you would understand that how difficult it would be. Whether to treat or not, when to treat, how to treat. So all vague areas when it comes to subclinical hypothyroidism in pregnancy. So I talk a lot about subclinical hypothyroidism because earlier I mentioned that treating overt hypothyroidism, it's not an issue. Overt hyperthyroidism, it's not an issue because we know that the mother needs treatment. So the problem is with subclinical disease. And out of subclinical hyper and hypo, subclinical hyper is not an issue because we know that it's commonly seen, especially because of the HCG effect, and So there's no confusion about that. We know that because the studies have shown that we don't have to treat subclinical hypo. So basically, we are left with subclinical hypothyroidism. So that's why I talk a lot about subclinical hypothyroidism. And in addition, we have another condition, as I showed earlier, isolated hypothyroxanemia, whether to treat or not. So these are the two entities we are left with, which we need to debate on, which we need to discuss about further. Yeah, subclinical hypothyroidism. Now, in the overt, it's usually even overt hypothyroidism. How it starts is that initially TSH goes up while maintaining free T4 within the normal range. So that's called subclinical hypothyroidism. And isolated, clinically they are okay. So there are no, even in overt hypothyroidism, most of the features are very vague. So because in the normal population also we do see features, it's like there are no clear cut, border as such, symptoms wise. So subclinical high TSH, normal free T4, whereas isolated hypothyroxanemia, TSH is normal, but free T4 is low. So from time to time we see that condition, and according to the literature, we don't know why that happens, but we do see. And in the current guidelines, they don't, there's no recommendation basically is whether to treat or not. So at the moment, what they say is that it's up to the clinician to decide whether to treat. So, at Jayavardhanpura, what I do is that if we happen to diagnose isolated hypothyroxanemia, free T4 would be, generally would be 0.7, 0.6, sometimes even 0.5, can drop to even 0.5. If it continues to drop, we start on a small dose of thyroxine, but we don't try to normalize it, and it doesn't normalize also, because we can be happy just for maybe for our personal satisfaction we start, but studies have not shown any benefit on the fetus by treating this entity. So I'm not going to discuss about these studies where they have shown, and actually these two are important, the CAT study and the US NIH studies, the two main studies with regard to treating subclinical hypothyroidism, and they have not shown any benefit. So that is one reason, it's conflicting data we've got, but these two, the two main studies have not shown any benefit by treating subclinical hypothyroidism. But having said that, I would also like to stress the fact that here treatment had been started a little later, not in the first trimester. Outcome is measured by the IQ of the offspring, but here treatment had been started not during the crucial period, around 13-14 so that's a limitation of the study when it comes to the final interpretation. So what are we supposed to do if you get an euthyroid mother with positive antibodies? Studies have shown that, again, couple of, small scale studies have shown that, some, very, remote complications, things could take place in untreated mothers. But all in all, so there's no clear cut association between a positive outcomes by treating this condition. So we are not supposed to treat just positive antibodies being positive in an euthyroid mother. So that's very important. So there's no question about subclinical hyperthyroidism in pregnancy, because a lot of mothers we see in the first trimester with suppressed TSH. It could be marginally suppressed, it could be severely, significantly suppressed. So it could be due to not that it could be, it is due to the HCG effect, and the effect is exaggerated if there is a twin pregnancy or if there is hyperemesis gravidarum. TSH could be very much suppressed, and sometimes in the normal pregnancy it should come back to the normal levels like during the course of the pregnancy, but sometimes we do see, I mean, even in late T2 T3, TSH being still suppressed. And this is another thing that we need to consider: can we do harm by over treating? Because I mean, you may realize that how difficult this condition is, because I mean, diagnosing itself is very difficult. Because diagnosis, I mean, it's very confusing. You know, the thyroid function tests are very confusing. The reference ranges, like a lot of, you know, the complexities are there. And it's a dynamic thing. So depending on which trimester the mother comes to you. T1, T2, T3, the same mother. And also, even if you diagnose it correctly, whether to treat or not at that moment is very, you know, decision making is very difficult. And you know, during the course of the pregnancy, what are you going to do? How are you going to follow the patient up? And so how are you going to alter the titrate the medications? So it's very complex because it's a very dynamic thing. I mean, okay, you see, you diagnose, you treat, it's not like that. You have to continuously, I mean, throughout the pregnancy, you need to see. You have to keep on titrating the dose. And over treating with thyroxine, studies have shown that a lot of adverse effects could take place when it comes to the offspring, the outcomes, you know, hyperactivity disorders. So many things have been shown, you know, as a result of over treating with thyroxine. Okay, so I would like to go back to the first slide. So let's discuss, go through the cases. Can you say that?
In for antenatal period, when to stop, and do we have to stop, or do we have to monitor and stop?
Yeah, now first trimester, we have to, I mean,
No, postpartum.
Postpartum.
Now baby has delivered.
Okay, so when, I mean, first trimester, we start treatment, and then postpartum, when to stop. So we have to find out what the reason is. Now, most often, like, it's due to Hashimoto's thyroiditis. So if it is Hashimoto's thyroiditis, I mean, regardless of the pregnancy, it will be there. So you need to monitor. So you have to look at the TSH, you know, prior to the initial diagnosis, and postpartum. And postpartums, definitely we must have given a higher dose because the requirement is higher compared to what it was prior to pregnancy. So it depends on the TSH. And by looking at the TPO antibodies also, we know that, I mean, whether it's going to be sort of a lifelong thing. So it's the overall thing. I mean, and it depends on, I mean, you know, from patient to patient, it would differ, decision making. So it's based, I mean, you have to do thyroid function test. You have to look at the previous results also. And then we can come to a conclusion. And postpartum, so there's another entity, it's called postpartum thyroiditis. So in euthyroid mothers also, due to autoimmunity, they can get initial, you know, the toxic phase, and they can go into hypothyroidism long term. So that's called postpartum, especially that happens during the first year, I mean, following delivery. So that's called postpartum thyroiditis. So the first case I've shown here, the presentation was at, you know, 10 weeks of gestation, and the mother had vomiting and weight loss. So examinations, there was a diffuse goiter, and the pulse rate was 100, and no tremor, no eye signs. TSH was suppressed to 0.01 and free T4 1.67. So what, I mean, those who are listening, so what do you think about, I mean, what is the diagnosis? What are we supposed to do? Yeah, so yes, vomiting. Yeah,
Very messy.
yes, vomiting is there.
And the weight loss is there.
Yes, weight loss is also there. So as Madhava sir says, pulse rate is 100, but you have to be very careful because pregnancy also we see all the features of hyperthyroidism. So don't just go by these tachycardia. It's common. And not feeling all right, so all the general symptoms would be there in the first trimester. So you have to look at it from the correct context, in the correct context. So TSH is suppressed. Free T4, mind you, these are the normal values. I mean, outside pregnancy, so always be mindful about looking at the pregnancy specific values. So it's slightly high, isn't it? The upper level is slightly, yeah, it's 1.7, and 1.67 means it's slightly high for the pregnancy. So the patient may be a little toxic, but we know that this is the HCG effect. So we are not going to treat because we know that this is not going to do any harm on the baby, and this is a very transient condition. So nothing is going to happen to the mother, just monitor. So we are not going to do anything. And we have seen, the mothers being referred to us, so having been started on carbimazole, propylthiouracil. Never do that, because this is the critical period where the neurodevelopment takes place, and you are going to make the child hypothyroid. So you're going to compromise on, the IQ, the final IQ. So don't treat. The second, okay. Yeah, because now TSH basically, I mean, TSH, because now we can, in another 1 month, we can repeat. I mean, we know that for the TSH to change, it takes about 2 to 3 months basically. I mean, now for example, let's say that, so this is a confusing area. In a patient with, I mean, not a pregnant lady, a normal patient with some thyroid disease, if you want to repeat TSH, let's say after starting thyroxine or after changing the dose of thyroxine, it takes about 3 months for the couple of months for the TSH to change. But here, by repeating it in 1 month, what we do is that we look at the trend. It's not the absolute value. So it's okay. I mean, in another 1 month, 6 weeks, you can repeat. But you can always do the free T4 again, just to see what is happening. So you basically go by free T4. Look at the mother, okay, look at the, whatever the clinical features, and you go by free T4. TSH can be, throughout the pregnancy, it could be suppressed. So
this TSH value will come to the normal.
yeah,
That's my practice.
yeah,
So if I see this type of picture, I'll do after 16 weeks.
yeah,
Because that's the time the HCG start dropping.
Yeah, now, but here the issue is that, sir, now when you consider the differential diagnosis, so we are left with it, not just the HCG suppression. So when you go to the next case, we will realize that Graves' disease in pregnancy.
Yeah.
So that is the differential diagnosis. So you have to actually, since the free T4 is not that elevated, because vomiting is common in pregnancy, because always, I mean, in every single mother, when you see a suppressed TSH, it's not the HCG effect. So sometimes, because Graves' disease is it's the commonest, in fact. I mean, during the in young females. So Graves' disease is a possibility. So, but we know that, looking at the mother, the clinical features, the presentation, and the history, we know that the most probable diagnosis here is HCG effect. And we are not worried, even if this is Graves' disease, we are not worried, because free T4 is not that high. So we need to monitor. So looking at the TSH, not seeing the mother, thinking that this has to be the HCG effect, we cannot do that. We have to monitor the mother till the free T4 become becomes normal. So you have to see the mother early on till the free T4 becomes normal, and we go by the free T4 here because TSH sometimes can remain to be suppressed throughout the pregnancy. So we see...
Can I interrupt you at this point? Now, if I say all these assessments should go in hand with T3 and T4 for both conditions, hypo and hyper, we are okay, isn't it?
No, sir. Now, the free TSH is the first test that we do generally, because we are not, it's not practical doing everything at the same time, because when you combine all three, it comes to about 5,000, I think. So, all three. And free T3 is not a robust assay. We are not supposed to look at free T3 because we cannot interpret, and we are not supposed to interpret. So, we do the TSH. And if there is a problem, so it's reflex testing with free T4, and then we have to interpret based on those two. So very rarely only we come across situations where we need to do free T3, sir. So, and for hypothyroidism, we don't look at free T4, and sometimes we do, but we go by TSH in hypothyroidism. But in hyperthyroidism, you can diagnose it with TSH, but for us to take treatment decisions and to assess the severity of the disease, we have to look at free T4.
Right, okay, got it.
So the next case, so again, POA 11 weeks, presents with vomiting, no goiter, TSH is very much suppressed, and free T4 this time it's high, unlike the previous patient, free T4 high. Okay, so theoretically speaking, we know that the probability of this being the HCG effect is high, but hyperthyroidism, Graves' disease, it's another possibility. But out of the two, HCG, because we see a lot of patients with this, due to the HCG effect. But no, sir. So here, no, sir. No, HCG effect, initially TSH is suppressed, free T4 high normal, but it can go up like this. So we call this transient gestational thyrotoxicosis. So that is the HCG effect, but the effect is exaggerated. So much so that the patient becomes hypothyroid. So earlier, it's not that much, but the effect is there, but it's not that much. Therefore, free T4 is not that high. Here, it's high. So that's transient gestational thyrotoxicosis. Lot of people, when I was working in Kurunegala Ratnapura, lot of mothers are being treated for this by general practitioners. So we are not supposed to treat this. It's just observation, and we need to monitor. How to monitor? We have to see them, because now we know that free T4 changes within 7 to 10 days. It's a dynamic test. Half-life is much shorter, unlike TSH. So you have to go by free T4, because we know that untreated, even like if this goes up, even if it's due to the HCG effect, if it's like very severe, we might have to treat transiently. But this I would not treat. It's not just the biochemistry that I would look at, but I would look at the patient also, but I would monitor. So this is transient gestational thyrotoxicosis. Next one, POA 20 weeks, no goiter, TSH 2.1, free T4 0.7, and then it dropped to 0.64. So this is the one I discussed earlier. So this is isolated hypothyroxanemia in pregnancy. TSH is within the normal range. Even with the pregnancy reference ranges, it's still within the normal range with low free T4. So statistically speaking, how low? 2.5 fifth centile below. So that's the cutoff. So that's, the statistically, that's how you define. So this is isolated. I would 0.7, I would not treat. I would repeat it if it's like lower than, if it continues to drop. continuously dropping, so I would start on a small dose, let's say 25 or 50, and I will monitor, but I would not try to normalize free T4. Next one, presents at 30 weeks. The mother is asymptomatic. TSH is 0.03. Free T4, it's 1.5. So actually, so I've done it. So let's go to the next one. Presents at 13 weeks. TSH 1.9. Okay, this is very important. TSH 1.9. Free T4 1.5. Free T3 4.7. So we get referrals like these. Now, because now if you happen to do all because I always say, we always recommend to do what is necessary. Don't ask for the thyroid profile. Don't ask for that. You have to decide, okay, what is expected? What am I going to see? What do I want to see? So based on that only you decide. Sometimes it will be just TSH. Sometimes it will be just free T4. Sometimes it will be only free T3. So if you ask for the thyroid profile, you will get this, all three, and it's very expensive. And you are not going to look at free T3. Because now see, free T3 is a little above the upper limit of normal, and you just ignore that. Because even, not just in Sri Lanka, even internationally, standards are not that good because the assay is not very accurate. So we would just ignore this, free T3. And the next one, presents again, let's say, presents in the late first trimester, and there is a mild diffuse goiter without eye signs. And here TSH is fully suppressed, 0.003. Free T4 3.2. So in the first instance, okay, it's only these two. Okay, so one would say, okay, could this be HCG induced suppression? Okay, it could be, but then you have to look at the mother. Okay, there is a goiter, but during pregnancy the thyroid can enlarge, so you have to keep that in mind as well. Okay, if there are eye signs, okay, problem solved. We know that Graves' eye disease is specific for Graves' disease, certain eye features, but here free T4 is a little elevated. As Madhava sir said, more than what you see generally with transient gestational thyrotoxicity. It's elevated. It could be 4, 5, 6, 7 even. And now there is a true doubt. There is a doubt. What is the diagnosis? Is it more likely to be Graves' disease, one would say, because there is a diffuse goiter as well? Then we could do the TREB antibodies. But, we have to remember that it's very expensive. We do TRAB every now and then at Javadanapura Hospital, but it costs nearly 10,000 rupees. But it's very useful if you really have a doubt, because there are management implications here, because if it's Graves' disease, you need to treat, but otherwise, if you don't treat, the outcome is going to be poor. So you can get miscarriages, IUGR. So, by doing TRAB, now here TRAB is positive, so we can diagnose without any confusion Graves' disease. And even without TRAB, here you need to treat with antithyroid drugs, PTU, or depending on the trimester, carbimazole. So, it doesn't matter. It's okay to have, it's not straightforward always. Like, could be the HCG effect or Graves' disease, but, so you have to monitor the patient, and you can always revise your diagnosis, then and there you have to take treatment decisions, even without knowing what the exact diagnosis is. So, the next one, again, presents, let's say in the first trimester, TSH 2.9. So what do? Because we know that, the target TSH, you'd like to have it less than 2.5. So it's more than 2.5. So it's the opposite of what we've been discussing earlier. This is, so towards subclinical hypothyroidism. So for a person outside pregnancy, this is normal, but in pregnancy, so we say that the preferred level is less than 2.5. So, at Javadanapura, of course, Dr. Shamoon is doing a study. So we do TPO antibodies in every mother. So the recommendation is that if antibodies are, so there's no clear-cut recommendation also. If TSH is more than 10, we have to treat. even with a normal free T4. So that subclinical hypothyroidism we treat if the TSH is more than 10, and if it's between 4 and 10, so we tend to treat Ajavadanapura, but the conflicting the data, and especially if antibodies are positive. Antibodies means TPO antibodies. If they are positive, we treat if the TSH is more than between 4 and 10. If the TSH is between 2.5 and 4, if antibodies are negative, we don't have to treat. If antibodies are positive, okay, we could treat because we know that antibody positivity means that it's going to progress and the mother is going to develop during the course of the pregnancy. Mother is going to become hypothyroid, so we tend to treat. So the next one, again, the patient is asymptomatic and the TSH is 7. So as I said earlier, okay, you can treat, can do antibodies. I would treat, and I would do another TSH. Why do I do another TSH? Not because I don't believe our hospital report, but says could behave differently at different times, and TSH also plus or minus there's an error. So always it's good to, if it's like borderline, if you see borderline values, you have to repeat it. So 7 I would treat. Persistently elevated, I would treat. So next mother, TSH is 34. Now there I would treat, because this must be, okay, you can do free T4, okay, it's good to do free T4, but I know that with this value of TSH, it has to be overt hypothyroidism. So I would treat, and I know that untreated hypothyroidism, I would see adverse consequences, especially with regard to the offspring. And in addition to that, there will be maternal complications also. And the next mother, again asymptomatic, TSH 1.9. Free T4 1.5. So both are well within the normal range, and for some reason TPO antibody had been done and it's more than 100. So more than 100, so certain ones you get, this is like must be a feature of the particular assay, because the upper limit you may not be able to define it. So it's more than what it says is that it's more than 100. So this is a mother with antibody positivity and being euthyroid. And studies have clearly shown that there are no benefits in treating these mothers, but you need to monitor the TSH. Monitor the TSH. At least 1 TSH per trimester we need to do, because the risk of progressing into hypothyroidism is high when antibodies are positive. Okay, so if there are any questions, I'm happy to answer.
Yeah. We have a lot of questions. We'll try to run through them very quickly. Thank you for reiterating in pregnancy lab reference levels on the reports are not valid. Can you give us rough guide on how we should go on TSH values for each trimester?
Okay, so TSH, so ideally speaking, we have to have population specific, trimester specific, and laboratory specific values. Now I'm happy to say that in 2015 we have developed our own normative data for thyroid function tests in pregnancy. So I didn't show that slide. So there we found that TFTs for our own populations, they are more compatible with the Caucasian data. Rather than the regional data. So when we compared with Indian and our data coming from our regional countries, they were more compatible with the Caucasian data. So that was the finding. So therefore, if the laboratories, if you see in the lab report, pregnancy reference ranges, lab specific Caucasian data-based reference ranges, you can go by those. So always, actually, in the hospitals that you are working in, liaise with the biochemical pathologists and ask them to enter those data, trimester specific data. I mean, if you don't have those, I mean, if you can't remember Caucasian data, TSH 2.5 in the first trimester, and after that, towards the latter part of T1, T2, T3, you can use 4. Those days, couple of years ago, the levels were slightly lower than that, 3, 2.5, 3 like, but they were changed subsequently due to the simple reason that, these conditions were sort of exaggerated and overestimated. So nowadays, during the first trimester, 2.5, and thereafter, upper limit would be 4.
Okay, thank you.
And free T4, actually, you have to look at the reference ranges given in the lab report. So free T4 levels tend to be a little higher in the first trimester, and they come down towards T2 and T3. So look at the trimester specific reference ranges.
Madam, what is the TSH level to diagnose subclinical hypothyroidism? Is it 2.5 or 4?
Subclinical hypothyroidism, now as I discussed, if the TSH, now by definition free T4 is normal, so if the TSH is more than 10, we tend to treat. If it is between 4 and 10, look at the antibody status. So if antibodies are positive, we could treat. And even with negative antibodies, if TSH is towards 10, for example, it's a huge range. It's 4 to 10. If it's like 9, 8, 7 repeatedly, you could treat, because that, outcomes you can see. If it's like 4, 4.5, if antibodies are positive, I would treat. And if they are negative, you can monitor even without treat, but I would treat if it's like above 4 persistently. I would treat with a small dose, but it doesn't matter if you decide not to treat. You have to monitor the patient. And TSH being the preferred level for pregnancy, between 2.5 and 4, lot of discussions are, the controversies are there, conflicting ideas. So if antibodies are positive, you could treat. If antibodies are negative, don't treat. But you could always monitor her with TSH. So it's a range basically. So there's no one particular cutoff, it's a range.
So I think the next question also you've answered. The next question is, if we are not treating subclinical conditions, then what is the place for screening? Symptomatic patient only needs to be tested, is it? So
that's what I showed earlier, because it's a very complex conditions. The case detection versus universal screening. Even outside pregnancy, the subclinical hypothyroidism, whether to treat or not, the doses, what to do, it's not clear. So just imagine, during pregnancy, it's like it has become more complex. So going by the symptoms won't do, because the same symptoms would be the same. Pregnancy per se, lack of energy and not being all right. All those things we see during pregnancy. So for subclinical, that's why we call it subclinical. So they are not symptomatic, if at all. Only the symptoms, things that you feel normal, symptomatology that you get during pregnancy. So you cannot go by the symptoms, but we can, if there's a strong family history, if there's a goiter, if there's autoimmune disease, there are, risk factors you can go through. If you're not doing universal screening, so mostly we do case detections, look at those, just go through the risk factors. And that's why I started my presentation saying that, it's a very complex subject, because we don't have clear-cut recommendations even internationally. So whether to treat or not, we don't know. And, especially, when Dr. Shamoon's the findings are out, of the study that is being carried out at Javadanapura, we could always, we can discuss. So, and also we can learn a lot from the countries which practice universal screening, Poland, Spain, China. So with time, I think we might get, certain, clues as to, what needs to be done. So very correctly that the doctor had pointed out, it's very, controversial and no clear-cut recommendations.
Next question is, if we diagnosed overt or subclinical hypothyroidism based on TSH alone, can we start treatment without testing FT4?
Subclinical hypo. Subclinical. Yeah. So TSH, you can, TSH, 5 or 10, 12, you can. But in other countries, of course, always, in developed countries, if you detect an abnormality, automatically they will do the rest of the tests also, because very rarely you get exceptions. Now, for example, now let's say secondary hypothyroidism, so you cannot simply diagnose with TSH. So once in a while, let's say, during your lifetime, during your career, couple of patients you might get, the exceptions will be there. So, as a practice during pregnancy, it's okay at least right at the beginning, once doing free T4, it's okay. But, if it is like clear-cut hypothyroidism, you can follow up with TSH, no problem.
What symptoms can gestational thyrotoxicosis present with?
So it's just like hyperthyroidism, thyrotoxicosis. There'll be tachycardia, loss of weight, not feeling all right. The general things basically is, just like, because, there's no difference when it comes to the biochemistry, because it's, having high thyroxine, symptoms due to having high thyroxine.
If they present with tachycardia and palpitations like cardiac symptoms, do you treat?
Tachycardia, so during normal pregnancy also there's some degree of tachycardia, and sweating. Palpitations, yeah. So, you can just monitor, because, having, simple around, 100, 105, 110, so I would not treat. But, and also we know that beta blockers, not just for a short period, but can have adverse effects on the growth of the fetus. So you can just monitor, and if it is due to gestational thyrotoxicosis, like with times, once the the vomiting and all settle, things would settle. And with Graves' disease also, where if you decide to start on treatment, with once with free T4 starts coming down, everything will settle. So routinely we would not give beta blockers to pregnant mothers.
Okay. Is isolated T3 thyrotoxicosis common?
Okay, so isolated hypothyroxanemia, it's one condition. So I think here's what he or she would have meant must be T3 toxicosis. So T3 toxicosis is not common. It's very rarely only we come across T3 toxicosis. So the differential diagnosis for T3 toxicosis, so there are mainly two. Number one is early phase of Graves' disease. So that's how Graves' disease starts. So right at the beginning, at the outset, so it's mainly T3s that will be elevated. And it's because most of the time we don't see it, because by the time the patient comes to us, T4 is elevated. And number two, solitary toxic adenomas. So those are the two conditions where you see T3 toxicosis. So if you happen to see, a suppressed TSH with a normal looking free T4, then you have to do free T3.
Madam, at what level of FT4 will you consider treatment at once TSH is low?
Okay, so could be transient gestational thyrotoxicosis, or could be real, Graves' disease. So you have to actually, there's no one particular cutoff. If I am to quote a couple of values, like if it's more than 7, so that's how, because upper limit, that's how we get in our reports, more than 7. So definitely I would treat. More than 5, I would treat. Okay, 3.5 to 5, I would treat. 3 again I would treat, but 2 to up to about 2.5 if the patient is all right, young and fit. If the patient is all right, 2.5, so I would wait, like especially if I'm thinking about gestational thyrotoxicosis and TRAB becoming positive. And you need to remember that even Graves' disease, full-blown Graves' disease, tend to go into remission during pregnancy because pregnancy is an immunosuppressive condition. So the severity becomes less as you go along the pregnancy. So, I mean, even if I decide to start treatments, I would very closely monitor, very frequently monitor, more frequently than is what I would have done, outside pregnancy, and titrate the medicine, titrate the antithyroid drugs. So marginally elevated values like around 2.5, I would be very cautious. Because like thinking that it's Graves' disease, if you happen to start on PT or carbimazole, the next week when you see, it may be like can hit the bottom, like if you overtreat it, if it is, especially if it is due to gestational thyrotoxicosis.
Madam, what are the indications for thyroid scan in pregnancy?
Okay, we very rarely only we do thyroid scans. I mean, it gives us clues as to what the underlying diagnosis is. Now, for example, in Graves' disease, if there's a doubt, I mean, you really don't know what it is, you can do the scan. Let's say you see a goiter, you don't know whether it's due to the pregnancy per se or Graves' disease. So there will be increased vascularity in Graves' disease. And severe Graves' disease, so there's this vascular pattern called inferno. Am I missing one? Yeah, thyroid inferno. So it's almost like inflames. So that's due to increased vascularity. So that is pathognomonic of Graves' disease. And if there are, rapidly enlarging nodules, the pain over the thyroid, so those are the indications for doing thyroid scans during pregnancy. Routinely, it's not indicated.
And the last question, can you explain about the treatment of hyperthyroidism?
Hyperthyroidism, okay. Now, transient gestational thyrotoxicosis, we can keep that aside. And if you happen to diagnose hyperthyroidism, so most often it's due to Graves' disease. Graves' disease in pregnancy. So let's say, TRAB is also positive and you have, sometimes may have eye signs. So you have to look at, now you can diagnose Graves' disease. So, but that itself is not enough. We have to identify the severity of Graves' disease. So that's done by looking at free T4. So free T4, how elevated free T4 is. And then depending on the trimester, you can decide on antithyroid drugs. Let's say if it's like 6, 7, during the first trimester, we can start the mother on PTU, propylthiouracil. And after that, we can consider carbimazole. We can use carbimazole. And the dose depends on the severity of hyperthyroidism. Severity means the biochemical severity, not the clinical features. It's the biochemistry. And then we can decide on the dose. So what is our target? So we are not trying to normalize it fully because we know that the fetus, it's very detrimental if you make the mother hypothyroid, because the fetus depends, especially during the first trimester, the fetus depends on the mother's thyroxine. So our target would be high normal free T4, upper normal to high normal free T4. So frequently you need to check free T4, you need to titrate, and it's only the carb titration regime. So we never use the block and replacement regime during pregnancy. So using the titration regime, and we have to liaise with the medical team, and we start on treatment, and most often the mother goes into remission during pregnancy. So, and as early as possible, we have to bring the dose to the minimum required dose, the lowest possible dose. So very quickly you have to come to that dose. You have to titrate down, keep on titrating down. And the fetal thyroid, it will start to form around 12, 13, 14 weeks of gestation. And after some time, the fetus will depend on its own. thyroid. But if you overtreat, what happens is that it'll go into the fetus and then can get a fetal goiter. And in Graves' disease, we have to be very careful. Always during deliveries, we have to make the team aware of the fact that the mother is having Graves' disease, and doing antibodies in other countries, they do in the first trimester at the time of diagnosis, and also towards the latter part of pregnancy, because it crosses the placenta and it will appear in the fetal circulation, and there will be transient neonatal thyrotoxicosis due to the antibodies in the fetus. So you have to expect, that has to be anticipated after delivery. So you have to actually sort of teamwork. So the management is very frequent visits. You have to make sure that the mother attends the clinics like as instructed, and very closely you have to supervise.
Thank you very much. There's one question for Dr. Visakha. This is about treatment of anemia in the first trimester. Now, when a pregnant lady presents with iron deficiency anemia in the first trimester, what's the plan?
Now I think in obstetrics you don't give iron during first trimester, isn't it?
We don't give prophylaxis, yes.
Yeah. But if it is necessary, you can treat. If it's very low, the hemoglobin, we can consider a blood transfusion less than 7. Otherwise, we can give, I think, no? It's actually, what do you say, madam? We don't. They say not to give. Yeah. But
actually, there is no evidence to
better to
treat.
Symptomatic. They can wait, no?
There's some concern regarding iron and its effects on the fetus, but there is no sort of proper convincing evidence regarding the harmful effect. The main concern with giving iron is, I think, that it affects the first trimester. Excessive vomiting can be made worse. That is why we avoid prophylaxis. But if it's deficient, I suppose we can treat.
Even no hard and fast rule.
Good evening once again. So on behalf of the SLCOG, it's my privilege to propose this vote of thanks for the hybrid lecture on anemia and thyroid disorders in pregnancy. Firstly, I would like to express my sincere gratitude to our two distinguished speakers, Dr. Visakha Ratnamalala and Dr. Dimuthu Muthukuda, for dedicating their valuable time and sharing their expertise with us. Thank you both for your outstanding presentations on two important topics which we frequently encounter in our clinical practice. I would like to thank those who participated physically here today, especially our two important guests, Dr. Ajitha Vijayasundara and Mrs. Vijayasundara. It's lovely to see you both today. And we had about 75 participants who were listening to us on Zoom. So thank you to everyone who's participating. And I hope you will be able to apply your knowledge that you have gained from these lectures today in your clinical practice and also share it with your colleagues. Next, I of course want to thank our sponsors. Mr. Ushan Piris, who's the Associate Director of Business Development at Merck, and Mr. Nuwan Samira, Sales Coordinator at Merck, for sponsoring today's webinar. Thank you for supporting the academic activities organized by the college. I'm also very grateful to the staff members of the SLCOG who have been very supportive and worked hard to coordinate and organize this hybrid webinar. So thank you all once again, and please join us on the ground floor to enjoy refreshments that we have arranged for you.